Good afternoon, ladies and gentlemen. Good afternoon, everyone. Welcome to the International Guest Lecture held in celebration of the 70th anniversary or Lustrum 14 of the Faculty of Medicine, Andalas University. This event is brought to you as a part of our commitment to advancing global health knowledge and fostering collaboration between institutions. We are honored to host a distinguished speaker who will share a valuable insight on the topic translating evidence into practice, education as a learning health system catalyst. I am Dr. Michia and I will be your moderator for today's session. Before we begin, let us take a moment to give our warmest welcome to our participants joining us both offline here in auditorium of Andalas University, Faculty of Medicine, and online via Zoom. Our Honorable Dr. Vini Fitriani, Pediatrician Consultant, as the Head of Department of Pediatrics, RSUP Dr. M. Jamil Padang. And now it is my great pleasure to introduce our keynote speaker, Professor Amy Gray. She is a distinguished member of the Leading in Learning Health System Global Health Team, University of Melbourne. Professor Gray is well known for her extensive work in medical education, evidence-based practice, and health system innovation. And today, she will be presenting on a topic that is highly relevant in today's healthcare landscape, translating evidence into practice, education as a learning health system catalyst. Please join me in giving a warm welcome for Professor Amy Gray.
Thank you. Yeah, we've got it. Thank you and good afternoon. It's a great pleasure to be here. And it's a great pleasure to talk on this topic because I'm very passionate about education and what it can do to change our practice. So a couple of things about me before I start. First of all, you need to know I'm passionate about education. I could talk about education probably all day. But I'm also very passionate about the fact that education does not always equal learning. There is a lot of teaching that happens that actually doesn't help. There is a lot of teaching that happens that actually doesn't change people's practice. And so I really am keen that we focus not just on education, but does that translate into learning? And does learning change what we do? And so I'm really passionate about doing education well. So I'll introduce the concept of a learning health system in a second. But how is learning related to health system change and leadership? I think about it a little bit in this way. So as health professionals, our goal is to achieve the best outcomes for our patients. And now, more than ever, that means we must continually learn and adapt what we do. There's more research generated every day now than there has been in years gone by. And so if we are not continually learning, we are actually falling behind. As leaders, like myself, I think we must help others in how to do this, and we must show that we are doing it ourselves. It's not enough to say we know we are experts. We must always be experts who are learning. We must demonstrate our own capacity to learn. A learning health system, for those who haven't been with me over the last 3 days, is this idea that we work every day in hospitals where we practice with our patients and we learn from that practice. We generate data about what we could do better and what gaps in the care that we deliver exist. We take best research and best evidence from around the world And we try to put that into our practice to get better outcomes for our patients. And ideally, we do that continually. We are always learning and we are always growing. This report from WHO talks about how important it is for every health system to be a learning health system, how every health system must be continually learning. And I come from a health system which is generally well-resourced and generally of a very high quality. But the world is changing very fast. And even in our health system, we are having to learn faster than we ever have before. Adopting AI, thinking about big data, thinking about advanced treatments that we can give to patients. The care that I give to patients now looks very different from the care that we were giving even 10 years ago in our hospital. I like this report though because it focuses on learning and it focuses on how we put learning into hospitals to change the care that we give. What this report does is emphasise that we all have a role to play. As individuals, we must learn. We must develop expertise and competencies to look after our patients. As teams, we must learn. We must learn to work together and deliver care together because that's how healthcare is delivered. And as organisations, we must learn to change our practices and make it the best quality that we can with the resources and the systems that we have. For leaders, what this means is we must support this process. We must champion learning and in doing so, we must champion education. So the culture that we develop for our hospital is incredibly important. And I want you to think about your own hospital or your own department or even your own clinical team. And I want you to think about the culture you have for learning. Is that culture strong or is that culture not strong? Yes or no? You don't have to tell me. Keep it to yourself. Have a think about it. Because if we are genuinely going to improve as hospitals and as health systems, we must have a strong culture for learning that tells us all that we could all do better. And if your answer to this question is no, I don't have a strong learning culture, then that is something that you can start working on even tomorrow. There are a lot of things that impact our learning culture. I'm from Australia. I work in a very high-level tertiary hospital for children. And even in my organisation, this is what I hear. This is what people tell me when I go to departments and go to different units and hear about what is happening for people day to day. They tell me that our workforce is not the same. They're not the same as they used to be. Our skills and our knowledge is changing. Our habits are changing. We are tired. We feel overworked. We don't feel like we're paid enough. All of this is having a lot of impact on workforces across the world. And it's not going to improve necessarily. It may get more challenging before it gets better. But the workforce is the heart of what we do. So how do we help them? How do we help them despite these difficulties? I hear that our patients are getting more complicated, and this is true. Most of the patients that I care for have medical problems that I didn't even learn about in medical school. They have incredibly complex problems that we are trying to solve and improve. The medicine has changed, and along with it, I think we have to change the way we learn. And finally, I hear, and I'm sure you can relate to this, that we don't have time. There's just not enough time to do what we do well. We all are doing more work than we feel like we can do, and there are more intrusions in our day than there ever was before. Often on my ward round, I'm talking about patients and I'm teaching, and yet my resident and my registrar are on their mobile phones or on their pages, answering calls and answering messages with no ability to just stop and think about the patient and think about their learning. So all of these things impact our ability to deliver education well, but we have the power to change them, and we have the power to change that culture in our institution. The other thing I think about is, what is the goal of our education systems? I think when I look at the past, we taught medical students to know everything. We taught them that they had to be experts and understand all the information that was in textbooks that was available to them, so that they could know everything about all of the important diseases. This is no longer possible. There is too much information. The information is changing too quickly, and none of us can truly be experts unless we are keeping up to date. So perhaps instead of training experts, we should be training expert learners. People who know how to find the right information, people who know how to use that information, and people who know how to think well about that information, to identify what is good information, what is poor information, and to synthesize that and solve the problems for the patients in front of them. So I'm arguing that we need expert learners, not just experts. Our expert learners must clearly be capable. They must have the skills and the knowledge to deliver safe patient care, but they must know that what is the right skill and knowledge today is likely to be different tomorrow, or in another year, or another 5 years. We must continually learn and adapt. And we must also think about the context where we are. What do we need in our own context? What I need in Australia looks different to what you need in Indonesia. What my learners need in a big public hospital is different to what people need in a health centre in a rural area. So how can we help people take that learning and adapt it best to the context they're in? So what is the challenge? I think there are many challenges. I think we have to develop this idea of an expert learner, and I think we have to improve the way we teach and learn. Because as fast as medical care is changing, the way we teach and learn is not changing that fast at all. And I think we need to think about how we do it. So I can't cover all of this topic today, but I want to cover 2 key challenges. The first one is, are our education programs really driving learning in the right direction? Are they working? And actually, are they needed? Or should we be doing something different? Number 2, how does our culture in our hospitals and in our institutions support learning? And what could we be doing better about that? I'll start with the first one. So, is our training or education needed? I have seen many, many times, too many times, people trying to solve problems in hospitals or with healthcare. And they see a problem with the care that they give and they think, this problem exists. This is not good enough. We must do a training. And before you do a training, before you go ahead and deliver education, I want you to stop and ask one more question. And that is actually, is training the right solution? Because far more often than I'd like to see, we deliver education when actually we don't need an education solution, we need a different solution. So if you need a different solution, stop. Don't pass go. Go and do a different solution. Don't think about education. When I'm thinking, is education my solution, I actually quite like this wheel, the behaviour change wheel. It's a bit hard to see on the screen in this room, but in the green centre of this wheel are the 3 things that we know change people's behaviour in clinical practice. 1 is their capability. Are they capable? 2 is the opportunity. Do they actually have the opportunity to do what you are asking them to do? And number 3, what is the motivation? Are they motivated to change? Are they motivated to take what you've taught them and put that into practice? What's important about this wheel is around the outside, the red and the grey tell you about the different types of things you can do to help people change practice, put evidence into practice. And what I want you to note is that only 2 of those things are education and training. And it's all the other things we forget to use sometimes to change people's behaviour. Sometimes we have to put restrictions in, sometimes we have to use persuasion or incentives. Sometimes we have to model things, not just tell people. Sometimes we have to change financing. There are a whole other range of things that we can do to change people's behaviour. And yet almost by default, we often come back to education and training. I'm just going to cover off what these other things are, just so that you have an appreciation, and next time you're faced with a dilemma of how do I improve care, how do I change behaviour, you maybe stop and just think, what else could I do? So in terms of capability is about education and training. It's about, do people have the skills and do people have the knowledge to deliver the care you want them to give? But then do they have the opportunity to do that? You've taught them something, do they actually have that equipment or that resource available? The physical things they need to deliver the care that you're asking for? Do they have the time? Does the work environment actually encourage that practice? When you are telling people to wash their hands, for example, is there soap or a hand wash nearby? But then what about the social opportunity? Does the social circumstance, does the social culture encourage those people to actually behave the way you're asking them to behave? Do senior people or other people in the department also follow that behaviour? Or something about them discouraging you from following what you've been asked to do? And then there's the motivation, which can sometimes be about your emotions. I just don't like doing that. This annoys me. I don't want to do that. I'm in a hurry. I'm stressed. I'm tired. Or it could be about your thinking. I know people want me to put this evidence into practice, but I just don't believe it will help. Or I believe it will cause problems, or I believe it will cause harm. So sometimes it's actually your rational thinking that means you are not motivated to do what people are asking. So I had them one by one. So before you jump to education, think, is there something else that you could do first? When we do turn to education, what I want you to think about is what type of education works. What is the evidence about the way we teach people and the way that they learn? And what I'm about to talk you through are 6 key things that we know makes education more effective, and yet most people don't use them. So number one is audit and feedback. If you can include audit and feedback in your training, it makes it much more effective. What is audit and feedback? It's looking at someone's practice or a team's practice or a hospital's practice and showing them the gap between what they are doing now and what we are aiming to do. If you are asking people to give a certain antibiotic for pneumonia, then what percentage of your patients are actually getting that antibiotic? Or is everyone following their own idea and their own guidelines? So the first thing we can do to make training more effective is to audit practice and give feedback on what people are actually doing, so they can see the gap between where they are now and where you want them to be. Number 2, target the change. What do I mean by this? I mean, don't try to teach people everything. Often in workshops and in lectures, we try to teach people 20 different facts, 50 different facts, many different concepts. And yet most of the time, all you can remember are maybe 3 or 4. So if you think something is important to teach, focus on what is the most important. Don't try to teach everything. Target your teaching to what really needs to change. That might mean you do it in small amounts, not in one big go. That might mean you do one topic at a time, not everything at once. But target your teaching to where the problem is. Don't try to cover too much in one go. Number 3, space your education. What this means is education delivered once, like this lecture, has not really been shown to be that effective. I know that by standing here and talking to you, some of you may remember something I've said. A few of you may even go and think, oh, I'll look into that, or I'll think about it a bit more. But most of you are unlikely to change what you do when you go back to your jobs. We do know, though, that if you can space education, instead of one lecture, give even 3 sessions over time, it is much more effective. Teaching a little bit, then allowing people to go back to work and try it, then bringing them back and teaching them a little bit more, then letting them go back to work and trying, and bring them back a final time to teach them again. So spacing education where you've got an opportunity to come back and talk about what you've tried, what worked, what didn't work, and what you need to learn next is much more effective, and yet we almost never do it. And so if you can find a way to follow people up after training, bring them back together after training, even for a short discussion, we know you are much more likely to get behaviour change. Number 4 is behavioural nudges. These, again, are quite simple, but people forget to do them. What is a behavioural nudge? A behavioural nudge is the idea that if I train you, say I teach you on a topic like pneumonia, and I ask you, I give you the idea about how I think you should identify and treat pneumonia, and you go back to your work, many things in your work are actually going to stop you from putting that into practice. So a behavioural nudge is thinking about that before you let the learner go back to work. That might be something as simple as saying, we've taught you a lot of things today. Can you think of one thing that you are going to try to do when you go back to work? So it's a behavioural nudge. I'm asking them to make a commitment about what they're going to try when they leave. A behavioural nudge could be equally as simple as saying, we've talked about a lot of things about how we want to manage this problem, but maybe when you go back to your hospital, you don't have the equipment or you don't have one of these drugs, and this is not possible for you. So can you tell me, when you go back to work, is this something you think you can do? If not, what would stop you? And let's try to work through what you can do instead. So acknowledging that there might be something that stops people from doing what you're asking them to do when they go back to work, and problem solving with that before they go. Behavioural nudges. The 5th one is change champions. These work a bit like spaced education, and they work a bit like behavioural nudges. They're people who believe in what you are trying to change. And if you deliver a workshop or you deliver a talk like this, they're the people that are then in the wards and on the ground who follow up and ask people how they are going, putting that change into place. Again, they're the people that keep encouraging when you hit a barrier, or keep problem solving when you think, I can't do this. I don't know how to make this change a reality. And change champions are often volunteers. They're often people who believe in what we are doing and what we are trying to achieve, and have volunteered for that role in their own unit or in their own team to try to bring that idea to life. So change champion. And the final one is communities of practice. Again, this works a bit like spaced education. A community of practice is a group of people who try to support each other, making changes from their education or changes in their practice. And they stay together, often now in online communities on WhatsApp, or on other forums, encouraging each other and seeking advice about the types of troubles they are having translating their learning or research into practice. Communities of practice are really, really powerful. And they may not be the experts, but they're the people that keep reminding you that you thought this change was important and that this learning. Stop for a minute and think, am I using any of these? If I want my training to be more effective, if I want to translate it into genuinely translate learning into practice change, what could I do better? And then the final piece of this is, what evidence do we actually have that our education or our learning is changing practice? When we do a workshop and we do an education program, what data do we have that actually shows us that we have achieved the change we're hoping for? More often than not, we don't have that data. More often than not, we have people that say, oh, I'm very happy with the training and I really enjoyed that training, and that training was very interactive and fun. But we don't have the data that says, and that training led to us improving what we do. And to me, that is something we should continue to strive for and keep trying harder for. Some of you have seen this already, but this is my example of where we really thought about how we get evidence about how training changes practice. This is work that to get
Recording in
high-quality
progress.
care for children in hospitals, in all hospitals. In fact, when I first started working in Laos, they didn't have a single written hospital guideline in their own language. And so our first job was to translate and print the guideline that you see on the top right. And we took those guidelines and said, okay, we're going to do training, we're going to do education. And that is the thing that will change practice. So we did a 5-day workshop across many hospitals. We did it at the highest level hospital, we did it in provincial hospitals, and we did it in the smallest district hospitals. And the 5-day workshop was a very heavy 5-day program. It involved PowerPoints, it involved hands-on practice, and it involved going to the ward and seeing patients with that condition so you could learn from the real patient. I'm not going to lie, it was 5 days and it was long and it was tiring. If any of you have been in a 5-day workshop, you know how tiring it can be. Yeah? So did practice change? Yes, it did. So this is from the paper we produced from this study. And what you see in the dark at the bottom is the scores of quality of care before we did the training and the guideline. And what you see at the top is the scores after we did the training and the guidelines. Now each of those points is for pneumonia, diarrhea, low birth weight babies, and encephalopathy. What you probably also notice is the change was big for some diseases and the change was small for other diseases. Now, firstly, I would say, if you ever get results like this, celebrate them. Most interventions in training show at most a 10% change in practice. So we were really excited because we showed a large change in practice. We were really proud of this, but we also looked at these results and went, why is it different? Why is it different for pneumonia and diarrhea compared to low birth weight babies and encephalopathy? We have a number of reasons why we think it's different. Number one, we taught about pneumonia and diarrhea on day 1 and day 2 of a 5-day course. We taught about low birth weight babies and encephalopathy on day 4 and day 5. I wonder actually part of the lack of change we saw is because people just did not have the energy to focus on the learning by the 4th and 5th day of training. So some of it may be our learning just got worse over that workshop. The second thing we wondered about is how we were training. So I can treat pneumonia and I can treat diarrhea easily as almost a single doctor. I see them, I diagnose them, I tell the nurses what drugs or fluids to give, and they are given. But I can't do that for low birth weight babies, and I can't do that for sick children with encephalopathy because they're complex conditions. They're complex conditions that require us to work as a healthcare team together, nurses and doctors. And we were not training people together as nurses and doctors. We were training doctors as individuals. So what I learned from this was we need to think about the way we train. We can celebrate that we change practice, but actually there's more work to do here. And in fact, there was even more work when we looked further at the smaller hospitals. So we got this change in the central hospitals, but when we looked at the district hospitals, nothing changed. We did the same workshops, the same training. They were really enthusiastic. They really wanted to change. They had the same desire to use those guidelines. But when we looked at their practice, nothing changed. And that was because we were taking 1 or 2 people from district hospitals. We were bringing them to a workshop, and then we were sending them back to these small hospitals where they were often working alone, trying to change care, arguing with other doctors that we should do something differently, that I've been taught this thing, and everyone else saying, no, let's just do the same thing that we've always done. We did not empower them. We did not help them to change practice. And they were only one person among many that could lead that change. So we had to think of something different. And so what we did is we rethought our education. We can't keep doing education that doesn't work. We'd already fixed the central hospitals. We didn't really need to train them anymore. We needed to fix the district hospitals, which saw the most patients and had the greatest problems with care. So we redesigned our education. Instead of 1 5-day workshop, we spaced our education. 5 one-day workshops. Remember I said spaced education is more effective. Instead of just training people, we incorporated audit and feedback. We looked at their records and we showed them the gap between what they were doing and what the guidelines said they were doing. We made the education as hands-on and as interactive as we could. And we threw away the PowerPoints because in fact, in most of these hospitals, the electricity kept stopping and the idea of using a PowerPoint was ridiculous. And we took the training to those hospitals so that those hospitals were learning in teams together and sharing the idea of the practice they wanted to develop. So what happened? Do you think they improved? Oh, before we do that, this was our data. So down on the bottom, you can see one of the hospitals. Up on the top, you can see the training. Very simple, doesn't require a lot of equipment, very hands-on simulation. And the data we were collecting from medical records and to give people feedback was very simple. Just checklists on what people should be doing and not be doing to follow guidelines. And we were giving them a score out of 10. So we could actually rate that score and look at change over time. And this is what we found. This is the data from 2 hospitals. You can see at the start, their scores out of 10 were 50%. Half of what they were doing for most of their patients was wrong. Some of it was harmful. And each visit, we went back and we kept collecting data. You can see each data point there. And what you can see is that over time, change model of training we should invest in for district hospitals, which is completely different to the model for central hospitals. The other thing that I want you to look at is what happened at the end. One hospital almost got to 100% and one hospital got to 80%. That's a 20% difference in care quality, yet they started at the same place. When we looked at our qualitative data, we realised that that 20%, the main difference was leadership. The leadership in that top hospital supported learning. It had a strong learning culture. It encouraged staff to come and it encouraged staff to improve. The bottom hospital had more equipment, more doctors, more subspecialists, and better conditions, and yet they didn't improve as much. So leadership and your learning culture is as critical as the way you train people if you want to improve care. The final thing I'll say about this example is I've been back to both of these hospitals. And the hospital at the top is still going very strong. It delivers excellent care, high quality care. The hospital at the bottom has gone back to where it started. So when we stopped training them and stopped looking at what was happening, their care went back to where it was before. So education is important, but more than that, the leadership that supports education and a learning culture is critical if we are going to sustain learning and sustain the change that we make. Okay, I'm going to end with this second challenge. So if that's the case, how does our culture and our environment support learning? So if we look at a system level, I like to think about the learning environment. This is a framework for the learning environment. You can see at the bottom, a learning environment includes our physical space, like this auditorium, as well as our virtual spaces, like Zoom here today. And on the right at the bottom is the organisational part of our learning environment. So the organisational structures, that's your curriculum, your accreditation rules, the rules that the government give you about what education you can do and not do, the structures you have to support education and the placements you have for students in hospitals. All of that is the organisational part of the learning environment. Sometimes these things are what we get most focused on and what we want to change the most. I work in many different countries in Southeast Asia, and almost everywhere I work, they say, oh, our building is not very good. Our simulation lab we don't have. If we had that, we could teach. But what I want to encourage you to think about is actually the greatest change can probably happen at the top. In the social part of our learning environment, as well as the personal part of our learning environment. How are we supporting people? So in the social part of our learning environment is who are we learning with and who are we learning from? How do you relate to your fellow students or fellow trainees? How do you relate to the faculty? How does faculty support you? How does faculty support each other? Is there a strong culture of actually encouraging learning, supporting learning, and creating a safe space in which learning can happen? This is actually some of the easiest work we can do. It doesn't require more money. It doesn't require more resources. It doesn't have to wait for another year or 2 years. This can start tomorrow. And yet it's the work we sometimes forget to do. So it's the work that I want to focus on now. Those of you who have been with me for the last few days will know I've talked a lot about psychological safety because I think it is fundamental if we are going to create a good learning culture. And psychological safety is this idea that it is safe to take risks, share ideas that might not be popular, ask questions that might look stupid, and even say that maybe you were wrong or you don't know something. And it's safe to do that without a fear of negative consequences, without being judged by the people around you. And psychological safety is the idea is that we all share that idea as a team. No matter how senior or how junior we are, we share that idea. Because if we can create that sense of psychological safety, then we suddenly create an environment in which everyone can learn to the best of their ability. So number one, We need to work on our psychological safety. Number 2, once we have a safe environment, I think we need to work on our mindset. So there's this difference between a fixed and a growth mindset. And often our training and our education train us to have a fixed mindset. A fixed mindset is the idea that I'm either intelligent or I'm not. I get high grades or I don't. It is a mindset where you expect reward. I'm very good as a student and I get a very high mark as a student. And that's what I do, that's who I am. The problem with that is if you think it is all fixed, then effort doesn't matter. How hard you try doesn't matter. People can give you feedback and you can think, yeah, I don't want to take that feedback. I'm good. I'm not going to listen. And so the opportunity to grow and improve is lost. I think we train people to be in a fixed mindset because in my institution, we take the brightest people from high school, we put them into medical school and make them compete against each other to get the highest score so they can get into the training program they want to get into. And in that training program, we celebrate high scores. So all we are telling people is your score is important. We are not telling them how hard you try is important. How you treat others is important. How you turn up to work and show care for patients is important. We are putting emphasis on achievement above the work that we actually should be doing as healthcare professionals. What we need to do is think about a growth mindset, shift to a growth mindset, where intelligence can be developed. We can all learn something new. That means we embrace challenges. Nothing is too hard because we're ready to embrace something new and take it on. It's the difference between someone saying, oh, I have to deal with AI. I don't want to do that. I'm too old. Versus, okay, it's coming. AI is coming. Let's work out how we're going to use it and use it well. So I can train my brain. I can change what I do. And effort is really the important thing. How hard I try and apply myself is more important than the mark that I receive. People with this mindset, they want feedback because that's how they learn. They learn from getting feedback. And they look at others around them succeeding and they are inspired by that, not threatened by that. They want to achieve and follow in other people's directions. So if we're going to have a good learning culture, we also need growth mindsets, and we need to train for people with growth mindset. And finally, we must have leadership. We must have leadership that supports this idea of a learning culture. We must have leadership that makes us feel safe and lets us learn in a way that allows us to make mistakes, allows us to admit that we're wrong or not always right, and use that as an opportunity for learning, not as an opportunity to judge people and put them down. And I'm going to finish before you have a chance to ask any questions with this idea. These are not my words. I'm not taking credit for these words. For the last 2 years, I've been working with an Asia Pacific network of leaders thinking about learning health systems. And these words came from one of our alumni, Raymond Keshwin, who's the most articulate man in our group. And this is what he said. He said, the heart of any learning health system is its people. We must trust our teams, support our leaders, and create the conditions where learning is part of how we work every single day. This includes addressing the rigidity that exists in all of our systems, the hierarchies, the rules, the things that we sometimes ignore but could change. Building new leadership capacity that is about learning and growth. And embracing open, honest, and collective reflection. And by that he means reflection on the work we do and what we could be doing better every day. A health system that learns is one that listens, adapts, and grows from within, from the people that work on that system every day. And we, as individuals involved in education, can make that change tomorrow. We can start small and start with our teams and build from there. So in summary, education is a catalyst for learning, and learning is one of the ways we translate research evidence into practice and change our practice. But it's not the only one. So before you go down a path of education, think, is there a different solution? Is there something else I should be doing first, or something else I should be doing as well as education? Education will not solve all your problems. Having said that, once we decide education is what we need, we must use it well. So much money, so much time, so much effort from so many people is invested in training and education. And we must prove that we are using that investment in the best possible way, and that investment is changing practice. Otherwise, we are failing our own systems. And if we think about our learning culture and how we can support these changes, I want you to encourage you to not just think about your buildings and your infrastructure and your curriculum. I want you to think about the environment you create for learning. How are you supporting learners, making them feel safe, and leading in a way that encourages growth? Thank you very much.
Thank you, Professor Amy. We will begin our question and Q&A session. You may take a seat in the front. Yes.
Okay, thank you, Prof. Amy, for the inspiring lecture. I think that I want to speak to my student also. Ya, jadi Prof. Amy adalah profesor pediatrik dari University of Melbourne. Ya, beliau general banyak beraktivitas di lapangan, di program. Ya, jadi beliau ini pernah tinggal di Kamboja, Laos ya, and Vietnam, Laos and Vietnam. Tadi ada contoh kasus bagaimana beliau membuat suatu pembelajaran tentang MTBS. Tadi lihat buku yang biru itu MTBS, manajemen terpadu balita sakit, itu versi Laosnya. Itu dari pembelajaran yang 5 hari mungkin membosankan menjadi pelajaran yang singkat 1-2 hari. Lalu di kurikulumnya dirubah menjadi pembelajaran yang singkat sehingga mudah dimengerti dan kemudian diaplikasikan oleh para dokter dan petugas kesehatan. Apa akibatnya? Dengan metode pembelajaran yang lebih simpel itu, maka terjadi kenaikan kualitas manajemen dari penyakit-penyakit pneumonia dan diare. Betul? Ya, itu salah satu contoh ya. Jadi yang disampaikan tadi adalah tentang bagaimana kita nanti akan melakukan pelayanan kesehatan itu harus selalu membuat suatu perbaikan melalui pembelajaran dari apa yang kita alami, gitu ya. Itu intinya. Nah, in this student come from different level. First one from the undergraduate that become a doctor in the primary healthcare. Jadi ada yang dari dokter muda yang akan jadi dokter umum ya, yang akan bekerja di level layanan primer. The second is the residents, maybe from pediatric, ENT, internist, and others, dan akan menjadi pelayan, memberikan pelayanan kesehatan di rumah sakit, ya. And we also have, kita juga punya mahasiswa S2 dan S3 Public Health. Bisa berdiri mahasiswa S3 Public Health? Kesehatan masyarakat, silakan. Ya, yang S2 So we have dan bapak-bapak ibu yang S2 dan S3 kesehatan masyarakat ini akan jadi manajer juga nanti untuk mengkoordinasikan semua pelayanan kesehatan, terutama di komunitas, ya. Jadi semuanya akan bekerja sama pasti. Nah, jadi setiap petugas kesehatan tuh harus memiliki kemampuan untuk menganalisis apa pengalamannya sebelum ini dengan mengumpulkan data, lalu itulah yang dianalisis kemudian digunakan untuk perbaikan. Mungkin kalau yang sudah di public health pernah melakukan PDCA, nah itu bagian juga dari pembelajaran Prof. Emi about the PDSA, yes, plan, do, study, and action. Nah, itu harus digunakan seperti itu terus nanti. Oke, bisa paham ya maksudnya? Nah, sekarang silakan bertanya. Tadi ada dua kata kunci lagi tadi bahwa untuk bisa tadi melakukan perbaikan-perbaikan itu kita harus merubah orang, people. People itu harus memiliki psychological safety. Do you understand that? Psychological safety? Oke. Anda bisa bertanya tentang apapun pada Prof. Emi, mungkin pemahaman tentang bagaimana mendevelop, bagaimana apa ide, kenapa Anda, terserah, silakan bertanya. Kita punya waktu untuk 3 pertanyaan. 1 dari dokter muda, 2 dari residen, yang ketiga dari teman-teman dari S3, PhD. Silakan dari dokter muda dulu. Ayo, ini ada yang di depan nih. Do you have question?
Question from young doctors?
Yes. Silakan bertanya. Tolong dikasih mic, kasih aja mic. Do you feel that you have psychological safety here? How can you? Ya, terserah pertanyaannya apa. Silakan. Ya, silakan berdiri. Oke.
Yes.
Ya, silakan berdiri, sebutkan namanya.
Okay, thank you, Dr. Pini, for the opportunity. My name is Gabriel. I'm clinical student from Public Health Department. I want to give a question to Prof. Emi Gray. I see that from the material is mostly the material is for the system for the for the leaders and for students too. But I'm interested the material about psychological safety, which is can affect our learning ability in education. And my question is, how can we, as a medical student, can adapt in society, which is the society is not compatible with our but with our with our belief, and I think that's can waste our energy and our skill that I think that and my question is, how can we adapt with that environment? Thank you.
You mean the environment in the hospital or outside the hospital?
In hospital and in the school, both of them.
Yeah, it's the first thing I will say about psychological safety is I think it's not talked about enough. In Australia, it is something that we talk about all the time, and we try to improve all the time because we realise it is so critical to learning, but also to safe patient care. And so the first thing I would say is it's something that the whole organisation needs to work on. It's not the responsibility of one person. But even talking about it is starting to do something about it. The second thing I would say is that the person that has the most difficulty changing psychological safety is the person at the bottom of the hierarchy. So even in my organisation, where we believe in psychological safety, and I try to be very careful about psychological safety, my medical students look at me as someone senior and scary. I'm not scary, but I know my medical students look at me and think, oh, she's senior, she's very scary, she's a professor. And so I almost have to be even more careful with what I do and say, because what I do and say may be okay, but my students can take it in a different way because I am a person in power. And because
Recording stopped.
Power, it completely changes how that is received by the person receiving it. So I think I can't answer your question easily because I think psychological safety is really the responsibility of the senior people in the environment and in the team. But I also think as junior members or students or other people in that environment where you are trying to learn, finding ways to speak up about it or to talk about it or even to share it with each other is a start. And I think you can do small things like asking, like my students, for example, on the first day I meet them, I say, I'm going to ask you questions. Not because I want to see what you know, it's because I want to see what you think. And if I know what you're thinking, then I can help you with your thinking. So I'm not judging you, I'm trying to help you to learn. My students will then be open to say, well, is it okay if I do this? Is it okay? And they can start to see what it's okay that I will let them do. But I think as students, it's difficult because you're in an environment where the psychological safety is created by the people above you. But you are students who are going to move through this system pretty quickly. You'll be residents, you'll be registrars, you'll be consultants. And if you can think about how important it is to you, then I hope that when you are more senior, you can think about what you do differently to the people below you. Does that answer your question?
So it's very ideal, and you know that maybe we not always have sometimes we don't have the psychological safety, or maybe law or little bit not complete for the psychological safety, but you can develop that in your workplace, in your academic leaders, academic culture, in your friend also. And we already have the training from Prof. Emmy to make the better education maybe for the student. Second one, silakan dari siapa tadi? Residen boleh, silakan Residen. Ya, silakan. Dr. Zaza.
Okay, good afternoon, Prof. Amy. I'm Zaza from as a pediatric resident. I have a question in a system level. What is the most important level that is needed to have a good learning culture? I mean, is it possible if a person is good but the organization is not good, or where do we start? Thank you.
Where do you start for a learning culture?
Yeah. Okay.
Where do you start? It depends. If you can't change the leadership above you, I think you can start with the people next to you. So for example, or the people below you. So if you're thinking, I want to change this learning culture, the first thing is, what do I have control of? I can't control that person up there, but I have my other residents, and we have medical students below us. And I remember what it felt like to be them, and we know what it feels like to be us. So I think you can work with the people next to you and below you to think about how you change that learning culture. Now, again, that can be as simple as admitting when you don't know, admitting when you think you are wrong, and seeking advice from the people around you. For the medical students who come and work with you, yes, they are often working with a more senior person, but you can change the way you work with them. One of the simplest things, one of the most obvious examples of a learning culture, I think, is the way we ask people questions. I've spent many hours talking to my residents about how they experience feedback and how they experience questions. And my residents say all the time, the senior doctor asks me a question and I think, oh no, I might be wrong. Oh God, what are they thinking? Oh, I don't know the answer. I do know the answer. Oh, maybe that's the answer. And their head is just spinning. Yeah? And the senior doctor looking at them goes, oh, they don't know. I'll just tell them. And then they get told the answer and they think, oh, I knew that answer. Why didn't I say that answer? And the reason you didn't say it is because you were afraid. You were afraid you were going to be wrong. And that is not a learning culture. That is a culture of judgment. So if you are working with students as a resident, the best advice I can give you is start by thinking about what questions you are asking. Don't ask questions to judge someone if they're right or wrong. Ask questions to try to understand what they think and what they know so you can help fill in the gaps. And if you ask a question and they don't answer it, remember how your head felt when people asked you a question and you panicked? Give them a minute and then just ask another question. Say, I know you're thinking about many things. Can you tell me what is going through your head? Can you tell me what you are thinking? Because that's much less scary question than needing to be right or wrong. So I think particularly as residents, you have power to change the learning culture next to you and below you if you work together.
Thank you, Prof. Yang ketiga, dari teman-teman yang S3, Kesmas, silakan. Dok, Pak, Bu, pakai bahasa Indonesia juga boleh, nanti ada yang translatornya. Silakan, Pak. Kira-kira dari pengalaman kerja Bapak Ibu bagaimana dalam mengelola, membuat suatu perubahan di manajemen kesehatan? Silakan, Pak. Ya, silakan. Ya, silakan berdiri.
Okay, thank you. My name is Fadila Ulfa from Public Health Program doctoral students. And we know that in healthcare professionals, resistance among healthcare professionals is to adopting the new evidence is a common phenomenon. And how can we overcome the healthcare workers' resistance to the application of new evidence in daily practice? And then, as we know that behavioral changes is a little bit big problem among in Indonesia. I think that's the question. Thank you.
What an easy question. So yes, we're trying to translate evidence into practice, and healthcare workers resist it. They don't want to change. So the first thing I would say is, do they really not want to change, or is it just hard? Is changing hard? So I think we have to give healthcare workers the benefit of the doubt, actually. Most of the time, if we tell them that they know something is better, they will try to do it. But in fact, their work is busy, they are tired, there's already too many things to do, and the easiest thing is to fall back to bad habits. So I actually think most healthcare workers want to change, it's just really hard to change. So then you have to think, well, why aren't they changing? Is it that they don't know it or they can't do it? So that's an education problem. Is it that they don't have the opportunity to do it? There's no equipment or resources, and unless they get them, they can't do it. So that's a resource problem. Is it a motivation problem? And the motivation, I think, is a really big problem. And it's not that they willingly think, I don't want to do this. They just think this is way too hard. And so that's where I think getting more people together to support each other for change, to celebrate, even just, as I said before, most interventions to change healthcare provider practice change practice by no more than 10%. And actually, that's positive. Like most of them are 5%, 2%, very small change. So if you do anything and get even a little change, celebrate it. Tell the healthcare workers they've done an amazing job, because that's motivating. It's more motivating to be encouraged than it is to be punished. So I think, yes, think about education and training, think about the equipment and resources, but most of it sits with motivation. And the motivation is often needing more people around you, needing more encouragement, needing more reminders that it's okay. This is hard. It's okay to not have done this yet. We just need to help you do it differently. Trying to make it easier to do the right thing. So if there's something in the system that's stopping them from doing the right thing, then make it easier to do the right thing rather than the right thing. None of it's easy, but if you manage to get any change, celebrate it. Celebrate it like you've just won the biggest prize in the world, because it's really hard to change things, and we should celebrate even small changes.
Thank you, Prof. I think that's so many insight that you already give to us about how to develop the psychological safety. Start from us, from ourselves first, to give the impact, and then send to around us. And the second one about the change the system. So start from ourselves also, from people, and influence people to do the right thing, to do the better services. And also the third one, we should have the collaboration, because you cannot do the work by yourself, but you should have the collaboration. Do you agree? Okay, do you agree about that? Okay. Apakah ada pertanyaan lain? Dari Fakultas Psikologi juga tadi banyak. Ada? Ada pertanyaan? Ya. Oke, Oke. Kalau begitu kita akhiri acara pada sore hari ini. Mudah-mudahan apa yang telah disampaikan tadi dapat bermanfaat untuk adik-adik semua, teman-teman juga, serta anak-anak saya sekalian. Mudah-mudahan nanti bisa menerapkan ilmu ini dan juga bisa mengerjakan pekerjaannya dengan baik, ya, sesuai dengan tugasnya. Sebelum dan sesudahnya saya ucapkan terima kasih. Thank you, Prof. Emi, and for your guest lecture for this afternoon. And I think that all the audience, the student, have the new insight about the leading and learning for health system. And you all are the key person for this, for the next future. Okay? Kita beri aplaus kepada Prof. Emi. Oke, sekalian berdiri kita foto bersama. Oke. Ya, kesannya semuanya di sini berdiri.
Baik, peserta webinar boleh kita mengambil tempat untuk foto bersama. Kalau tidak muat masih bisa berdiri di atas panggung.
lapis ya. Ayo, ayo, ayo. Nanti Pak. Yel-yelnya LLHS. LLHS. Yes. Dokter Nina, silakan Dokter Nina. Masih ada staff di sini, silakan duduk. Dokter Nina, yuk. Tiara, yuk.
Ya, Bapak Ibu peserta, adik-adik dokter muda, rekan-rekan PPDS, sama Bapak Ibu mahasiswa, silakan ambil tempat.
Please.
Kalau tidak muat masih bisa berdiri di atas panggung.
Ya, pindah ke atas panggung. Nah, tuh dia 3 deret ya. Oke. Oh, lumayan dia. Ya, kalau dia duduk dia nggak kelihatan nih. Ayo, maju terus. Ya, kamera online siapa? Udah ada? Oke. Boleh nyambung ke pinggir-pinggir ini nih. Duduk atau gimana? Di sini ya, biar rapat atau baunya. Masukin baunya masukin kiri kanan. Ayo. Bau masuk kiri kanan. Bau masuk kiri kanan. Udah? Oke. Oke, gaya formal dulu ya. 1, 2, 3. Kedua, gaya lustrum. L, begini ya. Setujunya begini. Oke. Ya, gini. Ya. 1, 2. Ya. Satu lagi sebentar. Ya. Satu lagi. Bebas. Ya, sebentar kita bikin video sebentar. Videonya pakai yel-yel ya. Bentar. LLHS yes gitu ya. Oke. Nanti LLHS-nya saya ngomong, nanti semuanya yes gini ya. Ke bawah gini ya. Oke. 1, 1. Udah, tag videonya udah hidup? 1, 2, 3. LLHS yes. Ulang lagi. Baru tepuk tangan setelah itu ya. Atau yes gitu ya. 2 kali yes ya. Yes. Terus tepuk tangan. 1, 2, 3. LLHS yes. Tepuk tangan. Oke, terima kasih. Tutup.